Thank you very much, Lisa, for this very kind introduction. And hello, everyone, to this brief talk on the TRI Academy on this wonderful October day. I'd like to start my little presentation with a quote I recently read in The Guardian, where a little dilemma that we face in the psychotherapeutic role, or well, a little dilemma was being described that we often face in our role as psychological therapists, which is that on the one hand, of course, we want to offer evidence-based psychological therapy in our clinical services in order to trying to support people with chronic tinnitus. On the other hand, if we are being very, very, very scientifically, we have to describe patterns and thoughts and risk factors and behaviors. And through this lens, if things get a little bit too extreme, we may run the risk that everything shrinks to the status of behaviors and patterns, but meaning, intention, and explanation may become irrelevant. However, for the human condition, for the experience of people who suffer from or live with chronic tinnitus, I'm going to argue that meaning, intention, and explanation are in fact very central to understanding the emotional worlds and their difficulties, and thereby also very important to address the difficulties individually and clinically from a psychotherapeutic perspective. So, a word on tinnitus to introduce my talk here today, but then we are quickly moving on to the core question, why are people actually distressed by the symptom? In order to try to explain this a little bit from a psychological point of view, I'm going to introduce a vulnerability stress emotion coping model, but will emphasize the meaning of experiences people make in order to try to discuss why it might actually be the meaning of experiences that may predict whether the tinnitus symptom is distressing or not for people. I'm going to explain or say a few words very briefly about the assessment or psychological assessment from this perspective of people with chronic tinnitus, and I'm going to close with a brief summary. As we all know, acute tinnitus is prevalent or is present for people if the symptom is being experienced for fewer than 3 months. 12-month prevalence lies at 12% here. I think this is data from Great Britain. And the main predictor for the onset of the tinnitus symptom is hearing loss. However, every fourth person who experiences tinnitus does not have hearing loss. And in clinical psychology, we talk about those presentations as medically unexplained symptoms, abbreviated as MUS. Or these days, alternatively, in the psychological scene, we can also find the term persistent physical symptoms, PPS, which are defined by physical symptoms that people tend to be very preoccupied with and tend to be very scared by. Chronic form of tinnitus lasts for more than 3 months. This timeline, less than 3 months, more than 3 months, is pretty much, or has been established by convention. And the main predictor for whether the tinnitus symptom becomes chronic is not only hearing loss, but as studies and studies and studies and studies have shown, emotional distress. With other words, if I'm being scared about the tinnitus symptom, or if I'm being angry or distressed about the tinnitus symptom, is much more likely to chronify. In other words, I am much more likely to not feel able to habituate to the tinnitus sound, to let it out of my sight or heart. And this preoccupation may emerge that I mentioned before as being a definitive characteristic of those persistent physical symptoms. The question, though, is why are people distressed once tinnitus onset? And, I might want to argue they're not distressed because of the tinnitus. Because we know from epidemiological research that it's only 7 out of 100 people with the same symptom who experience emotional distress. And 2 of those 7 people are so distressed by the symptom that they require psychological help or psychological support. But if 100 people hear or experience the same symptom, but only 7 of them are emotionally distressed, it cannot be because of the stimulus alone that we can understand why they might react in such an intense emotional or distressed way. In order to approach together with you the answer for the question why that is, why people are distressed, I'd like to introduce a psychological perspective on distress. It's not the right perspective, it's one perspective about man as amongst many. But as psychologists and psychological therapists, we don't consider tinnitus distress a symptom of a disorder as such, which would be rather a psychiatric or medical perspective. As psychologists, we believe that tinnitus-related distress is a meaningful experience that needs to be understood in context of a person's life and its impact upon relationships, identity, and sense of self of people. This lovely gentleman who I've presented here is Aaron T. Beck. He's the founding father of what's called cognitive therapy, a subsection of the umbrella of cognitive behavioral therapy. And he came up with a very interesting model as to why people are distressed, which can be summarized under the label vulnerability, stress, emotion, coping. What we mean by vulnerability from this perspective is that both you and I have psychological vulnerabilities. Those vulnerabilities are all of our autobiographical experiences that shape our view, our experience of relationships, identity, and self-worth. Against this background of our past experiences, of our personality, we can operationalize stress, the idea of stress, not as having too much to do or being overwhelmed by tasks or anything in the here and now, but stress from this perspective is being defined as the sum of current relational experiences that we have in the here and now that threaten our experience of relationships, identity, and self-worth. In other words, could be both your and mine stress with partners, it could be anxieties about losing our jobs and maybe feeling helpless or hopeless, could be challenges at work that we're facing because we feel we might not be up to them. It could be anything really, but the important thing is that what we mean by stress is the sum of everything that's going on in the here and now in our current life situations that somehow resonates with those psychological vulnerability themes that have been formed or that have emerged in our pasts and as the sum of our experiences so far. So we are having those psychological vulnerabilities in the background. We have our lives in the here and now, and those two dynamically interact. This may explain why, if I'm very, very vulnerable, relatively small stresses are enough to make me feel extremely vulnerable. Or if I'm not so vulnerable because I've had it quite nice, I've had supportive people in my past, I haven't made terrible biographical experiences, I can still experience very strong emotions if my current stress level, i.e. current threats to my sense of identity, relationships, and self-worth is very high. So as a factor, as a dynamic result of those two groups of influences, I might feel very fearful, I might feel very anxious, or I might feel very angry. And I will have to find ways to regulate those emotions in order to feel stable again. I will be trying to either turn into myself, try something in my mind or in my heart to try to regulate my fears, my worries, my anxiety, and my anger. Or I might be able to try to regulate my emotions in the interpersonal arena. I might get very irritable. I might start fights. I might withdraw socially from other people altogether. All of these different experiences and behaviors we could understand as attempts to regulate emotions that occur relative to an interaction of emotional vulnerabilities and current threatening relational experiences. From this perspective, this is where the tinnitus sound comes in as one stressor. That means the tinnitus symptom onset from this perspective is one stressor that I might experience that might pop up amongst many that I might be facing anyway, and that I will be interpreting relative to everything else that's going on and relative to everything I've been through, i.e. my psychological vulnerabilities. And depending on this interpretation, I might react with different levels of fear, anxiety, anger, different emotions, which I will then try or have no choice but trying to regulate internally or interpersonally. If we look at the literature, these arenas of vulnerability, stress, emotion, and coping are quite well researched. We know from a couple of studies that I have listed here on the left that the likelihood of chronifying the tinnitus percept, that is reacting with fear or anger to the tinnitus, is being higher if I've had it quite rough, when I've been exposed to traumatic experiences. We know from the literature that the anxiety and the anger I feel when I hear the tinnitus sound for the first time predicts how loud tinnitus appears to me, and it fluctuates according to how I feel. If I feel worse, tinnitus is much louder. If I feel better, tinnitus might be much less loud. And in order to try to regulate my anxiety and my anger, Froni Fieldsmeyer reported that people with chronic tinnitus might tend to use substances, alcohol, in order to calm themselves down, more so than the general population. In one of our own studies regarding psychological vulnerabilities, we conducted a count study that is currently submitted. You see here on the x-axis all kinds of different psychiatric diagnoses, and on the y-axis you see the percentage in our sample. The blue bars are patients with hearing loss, and the red bars are patients without hearing loss. And basically we can see two things here. Once, like everybody, the whole population of people who we saw in the clinic is highly psychologically vulnerable. Many of them have previously diagnosed emotional difficulties. And for some of these diagnoses, it even appears as such patients without hearing loss are even more vulnerable than those with hearing loss. This raises an interesting question because it might offer us the idea that, okay, if I have hearing loss, I might have a hearing loss mediated tinnitus symptom and then interpret it through the lens of my previous experiences and emotional difficulties. Or if I don't have hearing loss, the tinnitus symptom might emerge for other medically unexplained reasons, but I might still interpret it via the same route through the lens of traumatic experiences or my previous emotional difficulties. In a study that we conducted here in our center with a personality questionnaire, we handed a Freiburg personality inventory, a quite common standard personality questionnaire, to our patients in order to further explore psychological vulnerability in our population. And we found something really interesting because basically two personality traits in our sample went through the roof relative to the reference sample. One was our patients are very emotionally excitable. And on the other hand, they are very inhibited when it comes to allowing themselves to experience or to express their aggression. So this result demonstrates that somehow our patients here in our clinic come to us with an inner tension that oscillates between very, very, very strong emotionality and very, very, very strong attempts to inhibit that very emotionality. And we're only beginning now to understand how this inner emotional tension might predispose individuals to perceive tinnitus as threatening, and perhaps for the symptom also to chronify within their perception, within their experience. In another study, please look at the blue bar on the left-hand side here, we handed our patients a questionnaire where we asked, like every self-respecting psychotherapist would, about their experiences with their parents in the past. So basically, we went to all of our patients and we said, you know, how bad were the experiences that you've made with your parents? And what you can see here is really interesting. If you look at this red bar, the domain in the questionnaire is called punitive parent. How many experiences have you made with, punitive parental child rearing styles? Basically, all of our patients said, no, I've had great parents. What you see on the x-axis is the Cohen's d. So with a large effect size, pretty much every single patient who we saw in the clinic answered the question, well, what were your parents like, with great. Much more so than we would expect in the general population, which is being indicated by the zero axis here in the middle of the screen. So we can interpret this as meaning, well, great, our tinnitus patients have much better parents than the average person, than you or I. Or we can, of course, interpret this quite the other way, perhaps being mindful that there might be quite difficult experiences in the background, which are, however, avoided, or which our patients don't necessarily want to talk to us about just yet. If we move from vulnerability to stress, we were interested in finding out, well, what are current relational experiences that threaten our patients' experiences of themselves, their identity and senses of self-worth? And could it be that tinnitus is distressing for these people because it serves as a memory cue? They hear the sound and they become anxious because in the black box between hearing the sound and becoming anxious, they might remember something. The tinnitus sound might remind them of psychologically relevant vulnerability themes, experiences, and perhaps this might explain why some people react with such strong anxiety to the sound and other people don't bother at all about the same sound. So in order to investigate this question, my colleague Christina Beniotopoulou conducted a qualitative interview study. And basically, she played neutral sounds to chronic tinnitus patients, and she asked them, okay, what are your associations with these sounds? That's it. And we could show that the answers of our patients comprised episodic memories. Neutral sounds reminded them of something of their past. And the associations were also associated with emotional states that were linked to those episodic memories. For example, we showed our patients a ticking clock and they said, oh yeah, it reminds me of the living room of my grandmother and I loved her very much because I felt safe with her. Regarding moving down the vulnerability stress emotion coping level to emotion, we could also show, again, this previous study, that our patients, relative to the general population, showed very high levels of anger and a sense of emotional vulnerability with a medium effect size. And they tried to cope with these emotional states in 3 different ways. And those scales that you see there basically demonstrate the following. Detached protector means our patients have these very strong inner tension. They feel very angry and very vulnerable. And they try to cope with this in the detached protector mode, which you see on the screen, which means they emotionally dissociate. They detach from the emotional experience. They feel, okay, it's important to protect myself from emotions. So if you ask them as a psychological therapist, how did you feel when your dad yelled at you? They would say, how should I feel? Mr. Boecking, that's a really stupid question. The second coping style that we could find is called compliant surrenderer, which means that within interpersonal relationships, our patients tend to do what's expected of them, while at the same time feeling very, very angry underneath. Or, as being indicated by the bully attack scale that you see on the screen, a third coping style that was very eminent in our patient population was that if they don't detach or if they don't subjugate seemingly to perceived anger and attacks, they take the opposite way, they overcompensate, and they go right for the jugular. I don't know if any of you have had experiences of some patients who might be so afraid and so vulnerable that if we say one word, they really lose it and they might become very aggressive or perhaps sometimes even devaluing to us as clinicians or perhaps us as researchers as well. Importantly, though, and also a little bit at odds with quantitative research, we know all of these different factors might now predict tinnitus-related distress, or they might constitute tinnitus-related distress. But of course, this is a little bit empty. We say, okay, our patients have had traumatic experiences, they've had it rough, they might remember something, then they feel scared, and then they try to detach from their emotions or to use another way and attack people instead. So what we don't know when we take this perspective, which is called a list of factor perspective, this happened to people. We don't know why or how the events and the autobiographical experiences that our patients have been through lead to distress in them individually. What was it like for you when you had these difficult experiences is a very, very, very important question to ask, because no two people will be alike in their answer to this question, but both might share difficult biographical experiences as a quantitative research predictor. And this is a little bit of conundrum for us, because it is exactly this personal meaning that, well, that people attach to their experience that constitutes us and our inner worlds, that is the key integrative factor that actually mediates the psychological impact of external or internal events. If we now consider the tinnitus symptom an event, it is the personal meaning that might mediate whether people are actually distressed by the symptom or not. So which meaning do they attach to the symptom and why? Which might help us answer the question of why 7 people are distressed by the symptom and 93 are not. So we have all of these factors, but we need to link them from the psychotherapeutic perspective with what actually happened to an individual person and what all of these different experiences in past or present actually mean to them. Only if we know this, we can understand the emotional responses that result from the interaction of these experiences, and we can understand from a meaning-based perspective why they might feel substance use is a protective way in order to protect themselves, or why they feel that it is a good idea to protect themselves from hurt by being interpersonally aggressive or emotionally detached, for example. In order to approach these ideas in psychological assessment, in a simplified way, we are wondering, okay, when did the symptom start? When does it fluctuate? When does it change? What does it perhaps code symbolically? What does it stand for? What does the fear and the anger about tinnitus represent for people? And perhaps what consequences follow from the resulting distress internally or relationally, interpersonally? So we are trying to understand the emotional meaning of the onset situation. If it is true that emotional distress predicts chronification, and if it is true that we have a patient who was afraid of the tinnitus symptom when it first appeared, then it follows that the situation where the tinnitus occurred was emotionally challenging for our patients for one reason or another, which we don't yet know. So we are trying to understand the emotional meaning of the onset situation, and we are thinking both biographically and presently as we do this. We try to get similar ideas of the relational stress-related circumstance, which helps us to predict when the subjective experience of the symptom changes. So we are trying to understand symptom fluctuation as expressions of meaning-mediated emotionality in context of a person's current internal and relational life circumstances. And also we are thinking both biographically and presently as we do this. In trying to understand what all of these fluctuations and the meaning that is attached to the tinnitus symptom might perhaps code or cipher, symbolically represent, if you like. We are trying to explore emotionally relevant past and present experiences that are reflected in the appraisals, memories, and feelings associated with the tinnitus symptom. What are people actually talking about when they are talking about how helpless the tinnitus symptom makes them feel, for example? And we are interested in internal and external consequences of symptom fluctuation because we want to know, why was it that tinnitus got louder in this situation from your point of view? What happened there emotionally? Why is it that what happened there was so emotionally meaningful to you? What might it have had to do with? And how might we find different ways of perhaps regulating emotion that are not dependent on or linked to the symptom that much? I'm happy to say that psychological therapy is the only intervention, something is quite right about it. It's the only intervention that is being recommended in all different tinnitus guidelines that exist so far as potentially helpful. And within the psychological therapy scene, it is important to know that we now move away from disorder or symptom-specific approaches. So we are not thinking so much about a tinnitus therapy or cognitive behavioral therapy for tinnitus. And instead, we're adopting an individual meaning-oriented focus where we conceptualize the symptom, in this case tinnitus, relative to its function for relationships, identity, and self-worth, as I've presented. In summary, tinnitus stress is shaped by both auditory and emotional processes. While hearing loss can trigger tinnitus, its persistence and impact are strongly influenced by how the sound is appraised and integrated into one's broader emotional and life context. The meaning attached to the tinnitus sound at this moment is highly individual. Past experiences, our character, personality traits, attachment experiences, and everything that's going on for us in the here and now influence how we interpret and respond to the tinnitus sound, shaping whether we feel the sound is threatening, manageable, or perhaps quite overwhelming. Persistent emotional distress is often predicted by emotional vulnerability. Feelings such as fear, helplessness, anger, shame may be activated by tinnitus as one stressor amongst all stresses and managed through avoidance or tension in relationships. So if we are trying to address this closed circuit system and offer effective psychological therapy, we don't teach strategies or help people to think differently, contrary to popular belief, but we try to work with this meaning and emotion. We hope that this helps people explore personal connections between the tinnitus experience and their overall emotional experiences, help them process avoided feelings, and rebuild a sense of control and self-worth for them. And we find, to a good, some degree, that we can support people through this approach in reducing symptom-related distress and restoring their sense of emotional and psychological agency. Thank you very much. And last but not least, I've been asked to invite you all to the Tinnitus Research Initiative Conference next year here in Berlin, September 16th to 18th. I'd be very happy if I saw some or all of you there. Thank you.